All right, so one question that sort of comes up is, it seems like a theme for most of the talks are the importance of at a mobility conference, the importance of activity and trying to motivate it. You look at it in sort of the broadest sense, including a community view that I can imagine like Esther Dyson would have particularly appreciated. We also sort of looked at some of the aspects of the process of measuring the actual physical activity, which is some of what you were focusing on, and the tools for measuring how people actually walk and how people actually move. And then here are some ways one could use sort of first-person technology to try to assess that. And then you were sort of saying, well, if you took massive amounts of data, what are sort of some of the larger conclusions? Now, when a lot of people, sort of look at people applying technology to healthcare, they say, at the end of the day, you look at Michael Joyner, just as an example, like someone from the Mayo who's focused on this, and he sort of says, at the end of the day, people need to exercise more, eat better, avoid tobacco, and stay out of the sun. And you do more for health than almost anything else. How do you see each of your work? How do you react to that, and how do you see your work contributing to meaningfully improving health in that regard? How do you see the work, all of this sort of this broad knowledge leading to something that's really actionable for an individual? And actually, since you see people in clinic, maybe I'll put you on the spot first.
So that's a great point, and I agree with everything that you said. The hitch is that we've done a really poor job of accomplishing any sort of meaningful change in that direction. I think that the healthcare environment is a place where people can be motivated in a different way. And so when people come into the healthcare environment, if they have trust in their treating clinicians, then they're more likely to take those recommendations and move forward with them. But the physicians like me, even ones interested in this arena, can do little more than what you just said, which is you got to exercise more, you got to eat better, you got to spend less time in the sun, and you'll be healthier. And it doesn't. And so there's interesting things that happen. Christy Tompkins-Lane in the back did a study in patients with spinal stenosis, whose hallmark feature of the disease is that they can't walk. And she did a study looking at coaching them to walk more. And people thought, well, that's silly. Why would you tell spinal stenosis people to walk more? Because they say they can't walk. And their goal wasn't 10,000 steps a day because there's no way they could achieve that. Their goal was a small 20% improvement from their baseline, which was really low. And she showed that even with just a 15% change, there were meaningful health outcomes, there were good patient-reported outcomes, there were changes in their DEXA scan and other objective measures of health. So now we're getting to the level where we can tell one of those patients, you don't have to keep up with your 20-year-old son, or you don't have to get 10,000 steps a day. You just have to walk 500 steps more a day. And with tools like those that Abby has built, it becomes easily accessible to them.
So what you're talking about is sort of a level of coaching. We saw the same sort of thing in a diabetes study, which is sort of what Omad is built on as well, where basically hassling the hell out of people personally seems to really work effectively at the level that they did it in, that David Nathan's group at the Diabetes Center at Harvard did it, where they just hassled people, and actually in that case you were able to see that that was better than exercise. A challenge which Amad's trying to work out, which other folks are trying to work out, or how do you scale it? Let me go to Abby next. One of the approaches that you've described is sort of this avatar-based approach, and you're saying, well, in the setting that you described, the avatar-based approach for motivation seemed to work as well in the setting you described as calling somebody. I didn't have a good feel for the absolute amount of increase. I didn't know my impression was it was so hard to get people to move in a meaningful way and in a durable way to sort of have them lose and maintain weight. Do you feel like, that and when I think about what approaches work, for example, in the diabetes study where they had in this case it was nurse practitioners from the diabetes center called and just hassled the hell out of people in an incredibly specific and personalized way. I don't know. It's hard for me to imagine an avatar doing that. But you've done the research. How do you look at that?
Well, I'm going to answer sort of the broader question, I think, under your more specific question, which we have the right to do since I've got the microphone. I can answer any question I want. So I think that the two-prong answer is we have decades of behavioral science evidence, and it's stacked up really nicely in hundreds and hundreds of studies that show how to motivate different kinds of people over extended periods of time. The problem is all that evidence sits in scientific journals, and there has been no mechanism to actually translate it, to move it out into the public. So this is why we have thousands of apps that look really fun, but they don't necessarily harness everything we know about the behavioral science. So that's one part of it. I think the second part has to do with context, where it's not just about how people personally feel motivated, it's the setting that they're in. It's really the person by environment interactions, and we saw that actually in all of the talks. Everybody was talking about the fact that it's not just the individual, it's the different kinds of environments, and I actually loved the way this panel sort of worked out in that way, from the big view of countrywide environments to the visual view of what's happening, and Matt's as well. So, to me, it's really about that interaction, and there's so much more we need to learn about that.
But so do you, just to push a little bit on that, I mean, there have been, so many, even, companies that it strikes me, from McGonigal's company to a range of others, that strike me that they are aware of much of some of the behavioral data. They at least seem to be trying to deliberately apply it. And you'd think, if nothing else, the economic stakes of getting people to successfully lose weight, almost if you have, 2,000 entrepreneurs doing a random walk, and there's all this data around, someone's going to hit on it, but no one has, it seems. Why is it? I mean, is it just, I guess I find it hard to accept that the data is just sitting there and no one has looked in the right place.
Well, I'm talking about the scientific data.
Right.
So I'm not talking about the other data that Yuri and other people are mining so effectively, and we know all our industry partners are mining them very effectively as well. We'd love to hear more about this building the bridge that I think someone mentioned, maybe it was Scott mentioned this morning, I think is really key, and hopefully as we have more conferences like that, we'll be able to build that bridge better.
The flip side is also one of the purposes of entrepreneurship is really to pressure test even some academic research and find academic research that works nicely for publications and in journals, trying to extend it to deliver real-world benefit. So I'm just struggling, not with the research you presented, but trying to understand what are the blocks in what you've described as this really compelling body of research that says this should be really doable. It shouldn't be an unsolvable problem, but it seems there's so much challenge, and maybe hopefully over the course of this conference we'll get more ideas as to why.
Yeah, and just to follow on that, so I think there's kind of exploiting what's known about behavior to influence the apps we have today, but also I think there's a tremendous potential to really influence the technology community around what should be measured in the future, what are the constraints on that process. So little of that dialogue is happening either, and I think it's about bringing those communities together more effectively.
Do you have any?
So going to the first question, I think you could add, commandment 11, which is eat well, commandment 12, exercise. And when we start looking at the data, you kind of find out, more higher intensity, longer duration helps. But then that's the real story is much more nuanced, right? It's not about, yes, go and run, at 30 or 15 miles an hour for half an hour and you'll be healthy. You can't, right? So then you start asking, okay, if I have a certain budget, how could I best use that budget? And then it's already not clear. I think another important thing is that we are individual human beings and we are very different from one another. So what works for you might not work for me. So I think it's really about then building personalized recommender systems that will allow for good recommendations that have meaningful outcomes.
And that was one of the things that was so compelling about the motivational frames that Abby discussed.
Yes, and then I think there is more to it, right? It's not only who you are, but it's also about the environment in which we live, and the environment is both the physical environment around us, but also the social environment. And through these apps, we can start at least creating some of the social environment and kind of exploiting the things that Abby was talking
And that's
about.
really one of the points that I recall Sandy Pentland has emphasized in his book, where he talked about, on the one hand, texting people certain information can be useful for information transfer, but if you want to have people durably change behavior in something that's really difficult, it really did seem to be, if I'm remembering his data right, it's the first degree connections, it's the people who you were super tight with that were most likely to influence behavior change.
Yeah, so to amplify on that point just a little bit, one of the big barriers to developing effective clinical interventions has been the mindset of us clinicians, who tend to view our patients as rational creatures. And if we explain to them why it's important for them to exercise and why it's important for them to maintain a diet, et cetera, we expect them to behave like rational human beings. Whereas in fact, we don't spend much effort trying to figure out how can we motivate this person or how can we motivate this family group to change behavior and use some of the tools that our colleagues in behavioral science.
NPS in the context of a 15-minute visit where you have to check off a bunch of ICD-10 boxes. But yeah.
Exactly.
Ainur, wonderful to see you. Did you have a question?
Yeah,
Wonderful,
this was
Ainur
a
Sawyer.
fantastic panel. Thank you so much. What I've been appreciating in the behavioral science arena is that we do have the information, and it's in large sets of population-directed information that's trying to inform what we're doing. But I think what we're missing is the ability to do a personalized profile of a person's preferences so that we can understand what their drivers are at an individual level. Like we're getting that now with physiologic data and genomic data, getting more to precision tailoring or profiling of people, but we haven't done that yet about what incentivizes an individual. And I think through the work that you've done, I'm really curious about, are you gaining insights on how you might get to personal preferences? Because I'm working with a group doing AI on consumer analytics, and they're starting to look at the ability to create profiles at an individual level around what their preferences are, what would drive them, what matters. In orthopedics and my prior work in cardiac rehab, I have goals, I have clinical things that I think are important, but they don't really matter so much to a patient if they just want to be able to get to their daughter's graduation. So that's the thing I'm curious about, your insights around the personal preference motivators that we could look at.
Yeah, I think that's a wonderful question. I have found that people oftentimes don't know their preferences. So we have not actually found it very useful to ask people up front what they prefer, because what we find is that people are creatures of habit, and so what they will default to is the stuff that they're used to. And we found this in every single one of our studies, where before we randomize people to humans or computers or whatever the intervention is, we ask them, which one do you think you could do best in? And they all default to what they know. So if it's group exercise, that's what they'll default to. In fact, people actually could respond much better to other interventions that they haven't had experience with. So I think this idea of machine learning, where over time, people, the app is actually capturing your accelerometry-based activity, you can actually start to see those patterns that people are probably not even aware of, that on Tuesdays they're more active than they are on Fridays, and why that might be. So I think this kind of iterative machine learning process, and it's great that Mike McConnell's here since he is part of the team at Stanford that did the My Heart Counts app, and that's one of the issues that group is now going for, is to better understand people's behavior, not their preferences, their actual behavior throughout the week, and to look at the insights we can gain from that and then feed them back to the person. Did you know that, during this kind of condition or in this context, you're less active? Or did you know, that you tend to go for this kind of food on this day, or whatever the context is? So I think that's really where the gold is going to be going forward.
I would just add, I couldn't agree more. And I think to discover these things, right, asking people might not be the right way, but if you have enough data, then you will start to seeing these behavioral profiles that you can kind of just extract out, right? So with that, then I think one thing I wanted to add before we were talking, why startups didn't figure it out yet, once you have a startup, you are putting down like 10 fires at the same time, right? So, and you don't have the luxury you have in academia to really think slowly. So what's the point, right? The point is, I think, really to work together, right? Like that's why we engage with startups and say, hey, can we work on your data, and whatever we do will help you, and we'll be able to do solid research. And this way we push both of the fields forward. So I think that's we need to build that bridge, and we want to engage with other companies and with other entities who have large-scale data, are too pressured with their daily goals to really look deeply into it, but we can do deep investigation.
Yeah, I just wanted to say, I think for the technology folks, there's this issue to reduce the burden. So get the useful information, get the personalized information, contextual information, but get it in a way that doesn't obviously require the individual to make a big expenditure, and then give them a sense of what actually has been collected, and then give them the ability to control what happens with that data once it's out there, and then return to them things that are valuable so that they actually perceive this whole cycle as being useful, and not just useful in terms of their health, which is kind of an abstract goal, but useful in terms of very day-to-day things that might be beneficial. That to me seems like a great opportunity to combine the sensing, behavioral medicine, and the data analytics together. So.
Yeah, I thought the part about the revealed versus stated preference was fascinating. Did you want to add to this?
Briefly, yeah, I think that another important thing for us to all keep in mind is that the dollar drives a lot of choices that people make, and that happens at the individual level, but it also happens for at the larger level for the government, for companies. Device manufacturers and app manufacturers are interested in selling more of their devices and apps. And how can they do that? Well, by creation of tools that will allow broader application of these things. Companies are increasingly at risk because of the healthcare costs, and they're sharing some of that risk with their patients. So wellness programs have an opportunity to save companies money and promote better behavior. And the Affordable Care Act has tripled the amount of money that companies can put towards promoting better health in employees. So tools that solve those issues can sell more devices and make people motivated to be healthier. And then regional and local governments might be interested in some of that population level data and say, hey, companies are going to leave San Antonio because we have an unhealthy environment. What do we need to do as a community to invest in our community and make it healthier? So we have to think at that level, I think, to really affect a lot of change.
Okay. You had a question, and then we'll come to Michael.
Katrine Tudor-Locke. Shout out to my peeps at UMass Amherst who are watching.
Go Sox.
Yeah, exactly. So this is something I've been struggling with, but it sounds like you've made some inroads on this. I'm very excited to hear. How do you manage the ethics, privacy issues related to using these consumer device data, and who owns these data? And so from a researcher point of view versus the startup point of view.
That's a question for me?
Sure.
Sure. What we do is we try, right now this is just app usage data. So IRB is good. We anonymize. We don't look, we never look at the data by hand. We look at it through algorithms and through aggregation. And I think at the end, the company owns the data. And we have an agreement with them that we can publish and talk. So I think it works great. And in my career, I've been working, with Facebooks and Twitters and Amazons and Microsofts and small things and big things, and it always works out great. So I don't know. I always get this question, and I'm not able how to answer it because it always works out great.
Oh, good. So no problem. Well, maybe we'll get some insight from. So the next questioner can also comment on this. It's working. So Verily, which spun out of was Google Life Sciences, seems to be on this track, this cardiology track, where they just acquired or hired within the last year an amazing chief medical officer, a wonderful cardiologist, Jessica Mega, who I hope everybody here gets a chance to meet. And I assume that one of her colleagues over there. So I look forward to your question.
So I joined Jess at Verily. I had a couple of comments, some prior ones, but maybe I'll add a comment around who owns the data. I'd say when the Research Kit apps launched, that was actually one of the most common questions that we got. And I'd say fundamentally around citizen science, I think the the participant is the primary owner, so to speak, of the data. In an academic research study, we're become kind of the ethical custodians of that. You know, it's a challenging area. I think it's been of concern because some companies have felt like getting a lot of this data then becomes something they could leverage and sell, and you know, and confidentiality and privacy, all those things are concerned. But this debate as to, I mean, I think we want to try to promote that people are contributing this data and they are the fundamental owners of it.
And that's a real emphasis of both the Precision Medicine Initiative and the Research Kit Initiative. And I'd really direct you to your work, the pioneering e-patient consent work that John Wilbanks at SciOps has done. Tremendous. At Sage Bionetworks has done. Tremendous person, and has done, I think, really just leading work in this area.
I wanted to follow up on some of the behavioral side. I mean, I think that's one of the great things about the growth of mobile health. People have argued, well, what's the point of measuring if it's not going to change behavior? But it's really put behavioral medicine, you know, so much more at the forefront, because that's fundamentally, we can measure lots of things, but if we can't change behavior. And I think I'm particularly interested in this question of, are there tools that we can use to help figure out what are the specific motivating factors in an individual patient or participant, because there is a lot of variability, and asking them directly, as Abby has said, doesn't work well. But are there other ways to look at their behavior with their devices, or A/B testing of some of the different approaches so that you can get to what is working best? I think, you know, could be incredibly powerful. I mean, as much as we're all advocating behavior, you know, when people have done publications of how much, you know, the behavioral medicine knowledge is embedded in most apps that look at, say, weight loss and others, it's really pretty abysmal. So I think there is a huge opportunity in the industry to leverage the science that's there and build it into these systems.
Could we get a microphone so people who are live streaming can hear?
I just wanted to follow up on the comments about individual motivation. And among the two most interesting things that I heard in the panel this morning was this example, I think it was that Abby gave, where stories and videos were used to persuade the local community to invest in improving the walkability of the local area, and then your use of the large-scale data, where you found that walkability was associated with reductions in health disparity and obesity, which of course we know are linked to major public health problems and expensive health outcomes and so on. And so the thing that's interesting about that is, of course, walkability in a community isn't something that you normally can deal with as a clinician or on an individual level. But again, as I age, I'm particularly sensitive to the fact that if the community feels safe and if it's attractive, and if there are pathways, and if the pathways are well lit, and so forth and so on, you know, I'm going to get out there and walk. No matter where I am, I'm going to be getting my exercise. On the other hand, if the opposite is true, it doesn't matter if I'm wearing a device, it doesn't matter if I know, which I know very well, the importance of keeping fit. It's really hard to motivate oneself to do it. And so I think that it's just really intriguing to me. My students do videos and pictures, and they love doing it, and you know, they volunteer to do it, and I mean, it's fun. And so the idea that there could be some really low tech ways, actually, that the information you have could be used to motivate a local community to help themselves, I just think that's really exciting, because then the footwear and the apps and the devices all become fun for people to use, and there's a commercial market for it, and healthcare costs might reduce, and you know, I mean, all kinds of good things happen. But those are such, you know, they're really not terribly techy things to make happen. They're more the political process, actually.
I mean,
It's just a thought.
one of the things I think that is going to be interesting is I think there's a difference between observational data, such as this large scale, what you're presenting, and then some of what you were trying to get at, where you're saying, okay, this is, wellness helps. I mean, if you read Al Lewis, you read a lot of other people. The actual evidence that wellness reduces cost there's a lot of debate about how effective it is, and so the question in terms of actual data. So the idea of I strongly resonate with what you were saying. I think one of the challenges, if you improve walkability, if you invest the money to improve walkability or one of these parameters, it'll be really interesting. Not that that's not the right thing to do, but the question is, if you do it because you're expecting an economic return, I think that's going to be an interesting investment. On the other hand, one academic center that may start to pursue some of these issues, which I think is just a fascinating model, is Dell Medical School, where they're really sort of were built based, I don't have any connection to them, I thought it was a really interesting story. They were just founded in Austin. They're basically built trying to focus on community health, on trying to reduce the cost of medicine to the community that actually in Texas raised taxes, believe it or not, to start them. And their whole view is that most of medicine is, is based on the wrong models. They're trying to sort of reinvent it based on just what you were describing, sort of the community, more of a improvement of community health. And so they're highly incentivized from all the people in their community, especially to do research and to demonstrate that there's real benefit there.
Hello? Okay. So everybody's talking, mentioning walkability, walking. We deal with our patient populations, a lot of them can't walk. So any comments from the panel about individuals that have, one of their primary impairments is an inability to walk or walk without pain? For example, people with osteoarthritis, Parkinson's, as people getting older, post-stroke. I'm from Alabama, we're in the stroke belt. Could someone comment on that?
Sure, be happy to. So in my presentation, I discussed different look at the activity spectrum. And so one of the things that we're doing to approach this issue of trying to motivate change is understanding that people have a low threshold for change. And so you can't tell somebody with knee osteoarthritis they have to walk 10,000 steps a day, or even that they have to meet the 2008 guidelines for physical activity, because they can't. And if you read those guidelines carefully, they fully acknowledge that the guidelines don't apply to clinical populations that have mobility limitations. So using this new scale, we can look at somebody who has pain when they walk, understand where they're able to tolerate activity, maybe it's in the lower end of that light range, or maybe it's toward the upper end of it, and then give them goals that are small but meaningful, and that match their proven capabilities. So that's where we're going with some of the research. Whether or not it works, I can't answer that yet, but I hope that it will.
Hi, I'm Jayant. I'm from a company called Jawbone, does wearables. I have a two-part question. The first part is, how much data is too much data for the physicians to practice? It's very exciting that a lot of people here want to data mine, but in terms of actually going to a primary care physician and jumping that hard, making it meaningful to him, how do you guys think about that? That's first. Second, when you wanted to benchmark your patients before surgery, who pays for that benchmarking? And why should they pay for it?
So I'll take on the first question. So Gary Gold's in the audience here is a radiologist. He could talk to you today and tomorrow and the next day about an MRI of the spine and what parameters were used to set it up, the different sequences that are performed on the patient and how the patient had to lie during the scan, and then multiple different signal changes that are observed on the images that are produced by the scan, and could, like I said, talk for 3 days easily about a single study. I don't have 3 days to review the scan. When I see a patient in clinic, I need to consume the information from that scan in 2 minutes or less. And so what Gary does is he makes a report that's digestible and very easy for me to consume and apply to my patient in that clinic. And that's how I see all of this mHealth. We got to figure out how to make the information meaningful for that specific problem so that the physician can consume it very rapidly and apply it in a meaningful way. And we're getting there with some of the information, but it really hasn't risen to the level of clinical validity or ability to cause behavior change in a meaningful health way that physicians are interested in. And I think most physicians view it the way I described earlier, is that it's a curiosity and that's kind of neat, but I don't know what to do with it in my clinic.
Just to ask the obvious question, does it have to be the physician?
No, I don't think so.
Okay, one more question.
I had a question. My name is Rahul Jain. I'm here from the Louisiana Public Health Institute in New Orleans, and one of the things that has been coming to mind, and it's probably because I work in data harmonization, is really just what the thought process is for I guess a framework for interoperability, a framework for data exchange, and I ask that just with experience in health information exchange, experience in PCORNet and the pragmatic research. For me, applying data science to produce new insight, actionable insight, is very challenging without that capacity, that generalizability. And I don't know if y'all have any thoughts about how that can be approached, so we're not in a mess in 2 years.
So, I mean, the approach that we've taken in my lab is to combine both population science and precision medicine. So to gather insights, we have to know what happens at a population level, and we access available data sets to gain those insights. And then we apply them to individuals to see if we can derive meaning and do something at the individual level. And I mean, that's an approach that I think you see widespread across the panel.
That's almost a wonderful comment to end everything on. I think that too long there's been this idea that there are those who care about population health, and then there are those who care about precision medicine or precision health. And ultimately, of course, you'd like to have some integration where you have the view of improving the overall health of the population, but you execute that by really trying to focus on how to optimize and customize and how to ideally empower all the participants to optimize and customize their own individual care. So, and ideally prevention. So with that, let me thank all of the panelists and also the audience for wonderful participation. Thank you so much.